Hi, this is Dr. José Barrera from San Antonio, Texas. I'm joined with Dr. Jared Goldfarb and Dr. Cullen Taylor and presenting our upcoming manuscript on patient-related outcome measures, including nasal breathing improvement after functional rhinoplasty. This study considered whether caudal septal deviations can be improved, as well as nasal valve obstruction after endonasal septal extension grafting and functional rhinoplasty. Our primary outcome measure was to evaluate the minimally clinical importance difference, or MCID, in nasal obstruction and sinonasal symptoms in patients undergoing endonasal septal extension grafting by measuring outcomes including the nose score, the SNOT-22, the schnoz obstruction score, and the Epworth Sleepiness Scale. Now, in this study, patient-related outcome measures were utilized and showed improvement in breathing, appearance, and sleep-related questionnaires after rhinoplasty surgery utilizing endonasal septal extension grafts. Our goal was to show that the endonasal septal extension graft can be used in rhinoplasty to improve nasal tip support, as well as address nasal breathing issues. A retrospective chart review of 34 patients from my practice was used to evaluate patients with nasal obstruction and subsequently treat them with septoplasty, turbinoplasty, and caudal septal extension grafting. Patient-related outcome measures, including the pre- and postoperative nose score, SNOT-22, schnoz, and sleep quality as measured by the Epworth Sleepiness Scale, was utilized. The median age of these patients was fairly young, with a median age of 38.3 years, our range of 17 to 58 years. In this follow-up chart review, the patients underwent functional nasal surgery, but with all these patients, a caudal septal extension graft. Overall, we were able to demonstrate improvement in nasal breathing, as well as aesthetic improvements in the tip support and nasal base of these patients. Patients were able to be evaluated after patient-related outcome measure questionnaires and follow-up of over 3 months. Statistical analysis was used to show a significant difference of p-value less than 0.05 in this analysis. The percentage of patients achieving MCID for each patient-related outcome measure was calculated. A difference of -24 for the nose score, -28 for the schnoz obstruction score, -18 for the schnoz cosmetic score, and -2.5 for the Epworth sleepiness score, and -12 for the SNOT-22 demonstrated a difference in the patient score. Our surgical technique involved harvesting septal cartilage with a minimum 10 millimeter by 25 millimeter segment of inferior quadrangular cartilage, utilizing this graft as a caudal septal extension graft. A hemitransfixion incision was utilized to place the caudal septal extension graft. The plane was developed and extended superiorly to the nasal tip. The septal extension graft was secured to the anterior nasal spine using 4-0 PDS sutures. Hemitransfixion incision was extended into an intercolumellar pocket where the graft sat at the caudal end of the septum, and closure was performed with a 4-0 chromic suture. Postoperatively, 94% of patients experienced an improvement and overall mean reduction in the nose score. The SNOT-22 scores showed a 74% of patients achieving the MCID. SNOT-22 scores were also improved by minus 24 points. Regarding sleep symptomology, 61% of patients noted MCID improvement of their Epworth Sleepiness Score. And the overall Schnau score was reported to have improved as well in 76 of patients achieving MCID. When addressing nasal obstruction symptoms, the endonasal septal eccentric graft is a useful and reliable adjuvant procedure for aid in nasal dyspnea. Postoperatively, 100% of patients experience an improvement in nasal breathing as assessed by nose and schnoz obstruction scores. And of these patients, 94% experience an MCID and nose score and 76% in schnoz obstruction scores. The 3-month global period was used for assessment as endorsed by the patient's insurance carriers. Our practice continues to see patients long-term, but loss of follow-up due to patient preference was recognized as a limitation to the study. By supporting the nasal tip, the graft is able to help bolster the septum and support against caudal septal deviations. And we postulate that the septal eccentric graft helps to support the nasal valve and withstand the negative pressure of inspiration, which makes the nasal cavity prone to collapsibility, as well as fortify the nasal pyramid. This tenting effect supports the lower lateral cartilages and counteracts the forces of the Bernoulli's effect. The findings of this study also suggest an improvement in sleep-related symptoms. Nearly 1/4 of patients did not experience any improvement in Epworth Sleepiness Score, but overall, we were able to demonstrate that the MCID difference was important to record in these patients. Much of these patients had minimal to no symptoms, but improvement would be expected. Knowledge of this should give the surgeon confidence to discuss sleepiness with their patients when speaking of nasal surgery. We do recommend inquiry to sleep symptoms prior to performing functional nasal surgery, including the use of polysomnography. We see that both total and separately, the Schnau score significantly improved in both categories. It is also noted that there was a secondary effect that patients did experience an improvement in their mood, self-esteem, and aesthetic satisfaction with their nose as recorded by the SNOT-22. Although not used for cosmesis, the placement of the endonasal septal eccentric graft with medial fixation sutures does straighten the nasal base for patients with caudal septal deviations and a flaring medial crura. It is important to recognize the limitations of the study, including being retrospective. Also, patients had concurrent septoplasty and turbinate reduction. Alternative cartilage sources such as costal cartilage may be considered instead of septal cartilage when septal cartilage is not appropriate in patients. A future study randomizing patients to receive or not receive endonasal septal eccentric grafting at the time of septoplasty and turbinate reduction as a comparison group may be necessary. Long-term follow-up up to a year is also considered to improve the strength of the outcomes measured. Overall, our effort was to perform the customary 90-day follow-up period for nasal breathing, and our follow-up was 125.6 days with a range of 28 to 573 days. Schnau scores were followed up at an average 98 days with a range of 28 to 246 days. In conclusion, the collection and analysis of multiple validated outcome measures related to nasal breathing, sleep, and cosmesis have yielded that the endonasal septal eccentric graft could be a reliable and effective procedure to aiding patients and improving patients with nasal dyspnea. Patients with caudal septal deviations, nasal valve collapse, and poor tip support are especially strong candidates for this procedure, performed alongside septoplasty and turbinate reduction. I thank you so much for listening to this podcast. I can be reached at my handle on Instagram at Dr. José Barrera. You can also reach me at Facebook at Dr. José Barrera. You can reach me through contact on our website, drjosebarrera.com, or email us at admin@drjosebarrera.com. I thank you, the listeners. I thank the Facial Plastic Surgery and Aesthetic Medicine Journal, as well as my co-authors, Dr. Jared Goldfarb and Dr. Cullen Taylor. Thank you very much.